Orthopedics, crush traumatic amputations of digits. Here are some cases to illustrate some principles in youngish people, active working. Often best to go to a formalization of a traumatic amputation rather than preserving all the soft tissues and bone, which will prolong their rehab, cause them to lose a lot of time from work. For example, here's a 28-year-old man, fingertip crushed under a truck at work, traumatic injury to the digit, to the skeleton, to the soft tissues. So we just did an amputation, just distal DIP joint, and we're able to get soft tissue coverage, a healing stump at 3 weeks, and again showing healing, and a viable digit at 2 months. Here's another case of crush injury, 47-year-old merchant seaman, traumatic fracture dislocation, DIP joint, crush injury, and look how quickly it became dark, soft tissue envelope. So that was formalized and amputation DIP joint. Here's another case, 42-year-old man caught in a machine, the digit bone extends, a little bony stub extends beyond the soft tissue envelope, shortened up the bone so you can get the soft tissue to close over the end without too much tension. Healed well, but had a remnant nail, it kept growing back, had to be, the nail stub kernel had to be removed 2 or 3 times. Case 4, crush injury with degloving, 42-year-old man. Just involved the volar aspect of the digit. We thought that with a skin flap we may be able to close that over. However, it's not looking very healthy after 2 days, the skin flap, full thickness skin flap. So we formalized the amputation to level the DIP joint. Another case of crush injury, distal phalanx, 40-year-old man. It's still okay at 2 days. The bony destruction isn't too bad actually, just 2 fragments there. Another case 6. A stump post-formalization with traumatic amputation. So this is a previous case, and at 1 or 2 weeks he had cellulitis, an older man, and so we had to do a revision formalization of that amputation at 3 weeks. Here's another case, case 7, cellulitis of the ring finger post-operation, post-surgery. We had open reduction, internal fixation. So here's some cellulitis there which settled with the antibiotics. Here's another case, crushed comminular fracture, distal phalanx, 47-year-old male, but here's a worker. Here's a smoker, so this makes the chances of saving it very low. So he elected an amputation DIP joint. So in summary, a lot of these crush injuries, there's a lot of damage to the soft tissues, may not be evident in the initial phase. Where they're a worker, you might just talk to the patient and tell them that best to formalize it, certainly to level a DIP joint or a little bit proximal, rather than trying to preserve all tissues. So shorten the bone and close viable soft tissue skin over that distal bony architecture, and they're able to get back to work very quickly. Thanks for your interest.